They don't have to,
They
yeah.
do not have to be, no. So,
All right, is it 9 o'clock? It is 9 o'clock.
Do they have we published before we can raise them?
so,
Oh, actually, can we get this, can we just add this to the agenda? I don't wanna have this kind of conversation.
Yep, yep. yeah, it should be in public.
All right, calling the meeting to order. Review of agenda, shall we add? Initial review of that to the agenda, maybe in new business, top of new business? Actually, you already have it there, you're good.
Yeah, I was wondering about
Yeah,
that.
you already have it. So
Okay, I did put it on the
Yeah, we
agenda.
can cover it there.
I wasn't sure if I had, my staff wanted me to, so I was like,
Yeah.
sure.
Any additions? Okay, all right, then we'll move on to approval of the February 10th meeting minutes. So maybe have any changes. I was not there, so I don't know.
Did I not put the meetings in the packet? I may not
I
have.
don't think it
I
doesn't
may have
look like
missed
it.
that, guys. I am so sorry. You guys have it electronically, but I can print it off real quick.
We can, or we can just defer it to next time.
Up to you.
I think I read it, so.
Send everybody out an electronic copy.
Oh, he's got a copy right here, so, and Anwin, do you have a copy of the meeting minutes?
Yes.
Okay. All right, any changes?
Do you guys hear me okay?
Yes.
Yes. All right, do we have a motion to approve the February 10th minutes?
I move that we approve the February 10th minutes.
Second.
All those in favor say aye.
I
And I'm gonna abstain since I wasn't there, so. All right, anybody from public comment?
It's
I'm
just
scared of me.
us and Ann in the lobby.
All right, okay.
Yeah.
Unfinished business vacancies.
So I've posted for social worker and peer recovery coach for the QRT for the quick response team grant, and we'll see if we get any responses. I hope so. That's all I've been doing the last couple of days is DOP's Division of Personnel stuff, so
So it's on the DOP site, is it on our site too?
it is.
Promoted on social media and? all that
We
kind
will
of stuff?
do that once I get official clearance through the NeoGov site for the Division of Personnel.
So they have to first advertise it within and
Yes,
people employed by the state before we can put it,
Right.
before we can.
go real public with it.
Recruiting, yeah, people can be aware of it.
That has to internal post for up to 10 days.
Okay.
And then we can go outside of that.
Oh, just 10 days. Okay.
Yeah, wasn't that regulated? Yeah, 10 days internally. So if anybody who's a state employee or health department employee with across the state, they have first dibs.
All right, cool. Any questions? All right, new business. Proposed increase of clinical fees.
So what I was talking about before we went live is staff had brought to my attention that they're spending a considerable amount of time on certain items that we are not charging for, which would typically be charged at other health departments and other medical offices. I have a list right here. Some screening letters that we write, some types of some checks that we do, blood pressure checks, things like that we're doing gratis. I think we should probably consider putting a nominal fee on because they can often take a half hour or more depending on the service. And anytime that I believe that anytime we take up that much of the nurse's time, that's something that should probably be compensated. And I'm sure Dr. Reedy has an opinion on this too.
Yeah, and that's something we will need to be sure. Something as simple as a blood pressure check, like we do at a health fair, is one thing, but it's usually not that. Then people want advice, and it becomes a lifestyle management thing, and that is that's more involved.
Is that
But even-
billable to Medicare?
It can be.
It could
So
be,
it's so nursing, so if it's done by under specific guidelines, it can be as a low level, but it's still not zero. But those are, we do want to be accessible. But we also want to be able to hire staff so that we can have access. So
so it's just something to consider. Sorry, Elliot.
No, yeah, the question is, this is like where things become like gray areas, because we're not providing physician services. People have their own family doctors and stuff like that, so that's not what we provide. Are we a clinic though? Is that, do we function as a clinic? I mean, what,
So we
where is
do
it?
provide, we do not provide the full range, just like any practice out there limits what they do. There are some practices that have, you know, all encompassing,
So we are a medical practice.
yes, you're a medical practice. But with that, so things we bill are billed essentially in my name, you know, as the supervising physician. And where we have a nurse practitioner doing it, it would be under his or her license. And the staff needs to conform with those requirements. And you know, and they're aware of it, and we have standing orders of things that can be done. With these are the guidelines. I'm actually working on that with our nurse practitioner, because there's certain licensure issues she has to have with prescribing, having a collaborative agreement. And there's no way you can put down in writing all the circumstances. Then you get a textbook,
Right.
and that's always changing. So it's referring to certain guidelines, but for example, with nursing laws, an RN can delegate to non-licensed personnel and to, in some things, to an LPN. But for non-licensed personnel, it has to be a simple yes, no, that's very clear. It's not judgment. So there are very specific rules that we need to follow, but the scope of what we can do, you know, it would be much like another practice, that if I'm a neurosurgeon and someone calls in because they've got a rash, say, you need to talk with your primary doctor or go to urgent care. Same with the issue of, you know, we're going to do things that we are available 24/7, 365. That's a problem lots of practices face. In the olden days, which isn't that long ago, family practitioners were available for all ages, inpatient, outpatient, every day of the year. It's changed.
What we provide, is that at our discretion, or is it on state code?
But there's some things on the state code. There are other things, for example, treatment of hepatitis C. So there's certain services we could offer because there's a gap in the community. So hepatitis C screening or testing is testing and treatment. People have difficulty accessing the services, and so I'm going to be providing those. It's because people have difficulty getting it. It's a public health need, which I'll talk about a little more later. But it, you know, looks at our capacity, and then also in a business model, if it's widely available, is this something, you know, we can compete?
So a lot of the services we provide are up to you to decide.
So most that we are providing presently are required. But an opportunity to expand services for two reasons. One is to improve availability of care, and the other is to generate some income by increasing our market share, if you would. And those require, you know, need and ability of us to do it. And that'll probably also, you know, in future recruitment of staff would be, you know, who do we need to provide this service?
So, just on the blood pressure check, I just have one question on
Sure.
that, and that is, like, when you go to the pharmacy, do you have to pay for that?
Generally, no, if it's with the automated machine and that type of thing, but you're not really speaking with anybody. You're not sitting down with the pharmacist for another 20 to 25 minutes after that, which often does occur in this situation.
So we are not treating blood pressure.
Correct.
When people would come in, they
A
want
screen.
to check it.
Sure.
And that's really the gist of it, is it almost never just stops with that. Here's your numbers, have a nice day.
Right.
Like, here's your numbers, like, oh, that's high. What can I do to handle that, get that under control? And, you know, and the nurses are then part of that discussion.
And there are a lot of services that we could bill for that are simply advice that we don't. And many times people come in, have a simple question that we can answer. And often say, well, why don't you do this or that? But it's not really establishing a physician-patient relationship, in which case we would have to have a medical record, they'd have to be enrolled here. And
So if you bill, you will have to establish a medical
Correct.
record.
If you bill insurance, yes,
well, if we provide treatment,
right,
the law requires that we have a medical record. If I were to prescribe a medication for a family member's poison ivy, I would be expected by the Board of Medicine to have a document showing what was done on what day. You know, and that's just the standard of medical care.
And what kind of disclosure would you provide so that the person knows they're being charged for something?
it would be stated up front.
Oh,
Yeah,
That's
they-
something
they
we,
have,
that's right.
Once they enroll as a
No,
patient.
like
they-
surprise, you get the mailbox.
And once they come in, they sign, we give them notice of rights and
Right.
protection of information. And then they should be signing something that says, I authorize you to see me.
So what are your proposed increases?
So for blood pressure check from no charge at all now to a nominal $5 charge, head lice check. Current fee is $0, move that up to a $5 charge. We do write quite a bit of TB screening letters, the nurses do, and this can take about 20 to 25 minutes or so. And we don't charge for those, it's something we could charge $10 for, that's pretty common. And then some other screenings that or other letters and things that we write that we do charge $10 for. And we'd like to up that just a little bit because it's a little bit more involved than $10 worth of effort.
So I do assume then that you came up with this as a result of looking over your proposed budget.
No,
Okay.
this isn't going to close that.
How,
No,
about
no.
how many of these are done a month? Do you have any kind of averages?
I can get numbers like that for the real discussion. This is just a preliminary discussion, just so
Yeah,
it's
just
on you guys'
understand this.
radar. Yeah, and that's why I did this. I want to hear these questions so I can have a little bit more.
If this amount is only $5, this is not something you're gonna bill to insurance. This is something they're gonna pay out.
Yeah, this is an out of pocket fee.
Yeah.
This is a lot of times just a one-off service.
But there are codes that we would apply to this.
If
That are billable codes to insurance companies. So there's accepted billable codes that are.
So if it turns into a long drawn out thing, that's something where we might say, you know what, we should consider this more of an office visit related to this and then bill under the proper code. So those are things that we can do, but a lot of times they're just very, very quickly and billing insurance for it. It's just,
Right, and they're all by a licensed person.
Yep.
So it's not the clerk at the front desk doing it. They may
Right.
be involved in it, but the nurse then needs to do some judgment in there.
Yeah. so I'll provide those numbers for you. And I think the staff also have some other ones that they're going to include here. They didn't get to it.
Yeah.
So it's just something to consider. And you can say yay or nay on that.
Can I pause for a second? Did Ann Wynn drop off? I think she might have.
No, I'm here.
No, you're there. Okay, sorry, I wasn't seeing you in the screen, so I just want to make sure you're still there.
I'm listening.
Thank you, Ann.
Mhm.
But I don't really have much else to say, but I can
Okay.
provide more information. This is not a revenue generator in any way. It's just to make sure that we're not just taking a loss on dozens and dozens of these on a regular basis.
Right, people take advantage of,
Free services,
Yeah.
of course. And I think we all agree that paying for something increases its value.
Charlie?
All right, so we have the January 2023 financial reports and the preliminary for February. First, I want to go over the changes within the format. So based on discussions last month, I've kind of changed the layout of the key metrics sheet. You'll see at the top, we still have the reserve requirements calculation. In the center, we've added the financial summary, so you see how the month performed. So for January, you see you have the January numbers, but then you also have the fiscal year to date. Accounts receivable has changed that, or the layout has changed. So you see receivables greater than 10%. And they're aging, then everything under 10%, you see that aging as well in the percentages of each bucket. And then on the bottom, you'll see the percentage of significant receivables to total AR. So like here, we have West Virginia Treasury is 65%.
Yeah, I noticed that there's the non-treasury receivable is now grown to like a third. It was about 10% before, right? Or 5%.
Yes, it was.
It
And
also goes down in February,
So it's
down to 24 to the quarter.
And then, so the key metric sheet has changed. Then also, if you go to the last 2 pages, 3 pages, you'll see you have a profit and loss comparison. And again, that's a QuickBooks report title, comparison to prior year. So you can see how we performed last year and how we're performing this year.
surplus and
compare them.
deficit.
Huh?
Surplus and deficit.
Yes. So, wanted to go over, I think that addresses a lot of the questions that you all had last month. And, you know, they're there so we can monitor them. So January, key metrics were in compliance with reserve requirements in excess of $75,000. Financial summary for the month of January, there's a surplus of approximately $8,900. So that's revenue of $132,000. Salaries and wages, we're reducing that revenue by salaries and wages. We have $85,000 and operating expenses of $38,000. And I'd like to note in those operating expenses, there's $13,000 of vaccine purchases for the month of January
In the operating,
in the operating expenses. Yeah.
so it's a one-time expense.
Yes. And again, we've talked about this, then there's a mismatch between, you know, we pay for the vaccinations, revenue will come in later.
Right. We see
Yeah.
that in the February initial stuff.
Yes.
No,
So we do have a surplus for January of $8,900. Fiscal year to date, we have revenue of $623,000. We're going to reduce that by salaries and wages of $589,000 and operating expenses of $216,000. Leaves us a deficit for the fiscal year to date of $182,000. Accounts receivable, it sits at $171,000. Most of that $111,000 is West Virginia Treasury. The other 60,000 is small other receivables. They're all less than 10%.
So, I see a lot of yin and yang here, but the office expense. The budget was what, $2,000 and it came in at 8,700.
Mhm.
And then conversely, the supplies, the budget was 6,100 and came in at 2,100, so.
Yeah, there's probably maybe some coding differences.
Yeah.
Like some things are being coded to office expense instead of supplies.
Right, because they seem to be, you know, like paired items,
Mhm.
so, okay. They are.
Well, it's just something to think about for next year with the budget is like, if there is, you know, we should be billing as it should be billed or coded as it coded, but if there's an overage in one and an underage in another, maybe adjust them for next year.
For the budget number is
As long as the
is a-
total is fine.
right, is it in the budget and any projected budget, it's a overall operating expense. I don't separate it out by office supplies and things like
Well,
that.
they're just saying that it is actually.
Yeah, so,
Right,
when
but
you
not
do
in
the,
the projected budget.
yeah,
That-
when
we
we do
break
the
that out
budget,
later.
we just do there's just an operating expense.
Right.
And then I go through and by percentage, try to allocate it out to
I
each
see.
bucket.
Gotcha.
What actually is the write-off allowance that shows up in the P and L?
Yeah, so if there's an account that you're not going, like an accounts receivable, if there's money you're not going to receive, it gets written off and then that's what that line item is.
So how long does it go before you actually write it off?
So it'll clear out at the end of the year. So it's written off at the time it hits.
I mean, the criteria is if it gets into, let's say, over 90, does it get written off? or-
How do you determine?
Typically, we will let it almost go, we can almost let it go a year depending on what it is.
Okay.
And we'll bill it out as if we can, but typically, a lot of the times it's patient co-pays and things like that, and we're often not going to get that if addresses change and things like that. We're just never going to be able to catch up to the patients in those cases.
So
Usually for uncollectible accounts, I mean, you've done some research and you know you're not
Yeah,
going to get
you know
it.
you're not getting that.
So our AR is 171, sorry.
Oh.
171,000 is our accounts receivable,
Yes,
and our deficit for year to date is 182.3 K.
mhm.
Is that a cause for concern? Do they balance each other off? I mean, is that,
Well,
or is that included in?
Yeah, so the receivables are showing in revenue right now.
Right.
So it's not
That's
going
already
to,
in there.
correct.
So is that 182 a deficit? You think that's gonna be made up over the next 6 months? Okay,
Historically, that's what's happened.
okay.
Yeah, this time, if you go to the next to the last page, you'll see that this time last year, we were down 199. And we made that up and ended up with a surplus of about $70,000.
the environmental fees nearly
Right, you're
Fees.
sanitary.
don't come till spring. And that's it.
God willing that it continues.
Yes.
It will. I spoke to the planning commission not too long ago. There's another 240 houses being built in the next quarter.
Oh,
Well,
excellent.
the food service fees
Wow.
are, you know, unless you have all the restaurants closed, they will continue to.
Well, good.
You're cooking today.
We're not all in cooking, are we?
Are there any other questions anybody on January? Is there a motion? Oh, sorry. Brendan. Is there a motion to
I
accept?
move we accept the January financials. Second.
Okay.
Thank you. All those in favor say aye.
Aye.
Aye. Anyone opposed?
I abstain from voting.
Ready to go to February? Okay. All right. So February key metrics. So right now you see that it does not look like we're in compliance with reserve requirements, but I think it's just, we're at the end of the month, or we're just now reconciling, February. The bank balance is actually $422,000. I do not think we have $50,000 of outstanding checks. So I think we actually are in compliance with the reserve requirements, but because we haven't reconciled yet for the month, it's looking like we're not. So I think that's just a timing issue that will resolve next month.
It's also a shorter month.
And it's also, this is the preliminary report. It usually
Yeah.
takes about a
Yes.
week to 2 weeks to get everything posted for the previous month.
Financial summary. February, we have revenue of $104,000, salaries and wages of $82,000, and operating expenses of $5,000, leaving us a surplus for the month of February of $17,500. Fiscal year to date, we have revenue of $727,000, reduced up by salaries and wages of $671,000, and operating expenses of $221,000, leaves us a deficit of $165,000.
Going down.
Overall, revenue at this time is 19% less than what we budgeted. Salaries and wages, 11% less than what we budgeted. And then operating expenses are 19% more than what we budgeted,
How much?
19%. And that's mainly due to more vaccine purchases and some more travel and training this year.
So revenue's down 19%, and ops are up 19%.
Yep.
Okay,
But salaries and wages are less than what we budgeted so far, so that,
is
but
that
if you look
separate?
at the overall, like, if you look at expenses. We're, with them combined, we're on track. If not, that's at 51.8%, and in February, we're 67% through the year.
So salaries are not included in the operation.
Correct. Accounts receivable, you see that's gone up for the month of February, $245,000. We had another billing, we invoiced West Virginia Treasury for another, looks like $90,000. So receivable is greater than 10%, so it's at $185,000. Other receivables, $60,000, giving us a total of $245,000. 76% of that is West Virginia Treasury.
Is that the highest for the year?
I think it is
What, 76% or
the 245.
245?
It's a pretty big number.
So that makes our reserve requirement, especially since 75% of that's West Virginia Treasury, so we
Yes.
know it's coming.
Yep.
Absolutely.
But
Thank you.
Any questions?
I think a nice one to look at again is on the final page and look that we're closing the loss faster this year than we did last year. In a fiscal year where we did run a surplus. I think that's probably the projected surplus that I had sent you guys for this year, for this fiscal year, is probably
What is it?
right on track.
Yeah, so, yeah, on page,
The very last page,
very last page, I was gonna say page 3, but that's in period.
Sorry.
You can see July 20, you can see fiscal year 22's year to date versus fiscal year 21 year to date, and see that the gap is closing,
Oh, yeah.
the loss is closing quicker
Yeah,
than
so,
it did previously, even though we have much higher operating expenses, we are producing revenue quicker and more revenue.
Good shape.
Earlier in the fiscal year, so that made my heart a little
The
happier.
2020.
reports.
I agree.
Yeah, it is very
Did a
good.
good job.
So, and maybe I'm jumping the gun here, got on your 2023 estimate. I'm assuming this fiscal year 2023, a balance of almost $70,000.
Yep.
So a surplus of
A surplus of about 70K. So what I estimate using historic numbers, we're probably, and I estimated that we were probably going to be down on total environmental revenue a little tiny bit compared to historically, because in 21 we did 265,
Right,
and we did 140,000 in fees, fee services last year. And I only budgeted for 64, so it's possible that could even be a larger surplus.
Yeah.
But I'm not aiming to run a surplus.
no, but it's okay.
It's okay, but that's not the goal. The goal is to provide as much service, obviously, to the community as possible. And those are something we'll have to, if it appears that we're going to be running these types of surpluses like we have the last 3 years, then we'll have to figure a way to increase programs and things like that, make sure that we.
I just wanna
running
make
not
sure-
for profit.
Make sure it's very clear that we're on track.
We are,
with this
yeah.
surplus.
I believe we're on track to run a surplus, and somewhere of that number, and it's possible it could be significantly more.
Okay.
Hopefully the projections are right. I
this
think they are.
2023 estimate, that's what you arrived at last June.
Yes, I've also had to modify it. I have modified it recently. Yes, I've modified it using updated personnel costs that were not available to me at the beginning of the fiscal year.
It'd be
So
interesting in July to
see
when
what,
we
yes,
reconcile to look at what actually happened with our projection when we approved current
So the-
fiscal year's budget.
I actually have that number in my head. It was about $76,000 surplus is what I had estimated going into fiscal year 23. When the budget that you guys signed off was that's what I estimated the surplus would be, about $76,000. Running using the numbers we have, and it looks like we'll be pretty darn close to that. And
Pretty impressive, actually.
No, it's wonderful.
so,
Big
But I-
difference from a couple years ago.
yes, well, there's. Hopefully my next year projection isn't, well, let's let Charlie finish up and we can step into this.
Oh, I think I'm done. Did you guys get what you needed from the updated reports?
Very good.
Okay,
Very helpful, thank you.
all right, thank you. I appreciate your time.
Thank you, Charlie.
Have a good day, Charlie.
All right, financial report, or, go ahead, Gina, with the,
No, we have
are
to,
you talking about, we're not accepting?
yeah, we don't have to
or-
accept these,
No.
but we're finished up on that. Everybody thinks.
Yep.
Okay, awesome. So let's talk about the budget real quick here. The budget numbers are updated. I was originally predicting, I think I gave you in January, something around $240,000 budget deficit for fiscal year 24. Looking at revenues this year, looking at personnel costs moving forward. I had made some slight modifications to that and come to the more comfortable feeling that it's probably going to be more around $130,000 budget deficit, possibly. Reason I did that was I have a much more firm grip on what the staffing levels will be going into fiscal year 24. We're pretty much fully staffed now. We have a good feeling that I don't believe we'll be adding any staff. What about you, Gillian? Nope. So I don't think we'll be adding any staff beyond what we have now. I have a good a firm grip on what their salaries will be going forward. And I was able to modify that down from 1.3 million in personnel cost to about 1.06 or so. So
When you say fully staffed, sorry, Elliot, you got these two vacancies here. These are gonna be funded by grants, so
These are-
budget neutral. You're talking about staff burden to the program.
you got it.
Okay,
Exactly right.
just wanted to confirm that.
Absolutely. This is traditional staffing, not grant funded staffing. Now I'm extremely conservative in this. The truth is that the epidemiologist position is mostly covered by a grant. And the threat prep coordinator position is 100% grant covered. I included them as a cost because I cannot guarantee that grant will come through in fiscal year 24. It probably will. Both of those grants probably will, but I can't guarantee it.
That's actually the line that sticks out in all of these budget projections is that's the big variable, it's grants.
Correct. Correct.
And
That's where you see
started
that.
out as a trickle and now all of a sudden it's a flood. And
Now it's a trickle again.
we can't assume that the flood will continue.
Correct.
So, but yeah,
So, but
that's interesting.
But the federal threat prep line here, that is actually the line that covers the threat preparedness coordinator. So I count it as income, but I also count that position as an expense also, so. Instead of just zeroing it out so that it's accounted for. So if we remove that grant and we don't have it, we'll still be at that number for the expense.
COVID related grants will be over.
They're done.
in this-
End of
not
fiscal
part
year
the next
23.
fiscal year.
So that is amazing, because you're looking at over the last 5 years or so. And a 20-fold increase in grant,
Correct.
and that's really extraordinary.
But most of those grants will be drying up. That doesn't mean we're not trying to hit them as hard as we can to the end of the fiscal year. That's in our interest to do so. They also want us to spend as much of that money as possible. The state would prefer not to remit that back to the federal government. So they're encouraging us to spend it, but we have to do it ethically. We can't, if we're charging for certain services, we can't then double dip on the grant. That's just not ethical. It's not legal.
So as we get closer to when we need to approve this budget, which is May.
I guess.
How much more do you think you'll be able to close on this 128? Because I think that's a pretty big number.
Here we go. You
I
ready?
mean, of course, we'll also know better what surplus, if any, that we're gonna have. So I assume we'll be able to roll some of that over. Maybe
Sure.
that's how it's functioning, but how how much closer
That number seems to be purely a function of your estimation of
of
grants.
grants, right?
and
That's,
being-
I know.
And state aid.
Yeah.
And state aid and potential county aid, of
Right.
course. So here we go, ready? This is for Brandon, because this is new,
I
because
hope
this is new
everybody
to you
else
guys,
is.
everybody else too, it's a refresher.
Yeah.
And we talked about this last year, everybody, so it's, currently, I've left state aid static due to the fact that we have not yet received the updated state aid amounts. That changes based on projected projected population and population growth and things like that, and other key metrics. If you didn't know, and just a refresher, state aid is based on a formula that considers population and other demographic data to establish what portion of the total state allocation that each of the 48 individual health departments receives. There's a base amount for total population, then there are coefficients that adjust the amount up or down based on average income, health, education, average age, and population density of each county. So as we are the wealthiest, healthiest, most educated, youngest, and have moderate population density, we have one, if not the lowest, one of the lowest coefficient multipliers in the state. It actually removes money from us and that reallocates it to states that are, or counties that are older, less healthy, less wealthy, and more rural. And although we as an organization, the administrators across the state, we were anticipating a restoration of the remaining 13 percentage points on state aid that was of the 25 percentage points that was removed in 2017 from funding. That didn't pass out. So that didn't make it out of the Senate, didn't make it out of the House. So we're still down about 13% from the amount of state aid that we were receiving in fiscal year 2016. And when considered for inflation, our state aid should probably be around about $475,000, and I'm anticipating about $420,000. So, but that still may go up. There is a grant coming from the CDC. It's already been applied for. It's already been awarded. Just hasn't been figured out how they're going to disperse that. It's a pass-through from the CDC through the state. The state is keeping 40% of the total of that and dispersing 60%. It's supposed to be supporting local health departments.
Wait,
And-
did you say the CDC?
CDC, yes, is giving what's called an they're calling it an infrastructure retention grant. So
A majority of our state monies come from federal.
No, I get that. It's the whole, what 40% are they keeping your government
So-
agency?
so-
Where did it come from?
So the money came from, it was roughly about $17 million directly to the state of West Virginia. It was supposed to be passed through to the local health.
Right,
That's what it was earmarked for. The state was allowed to keep anywhere from 40 to 70% of it for
so the
themselves.
state.
The
okay,
state could
I thought you
keep
said
For the
CDC.
state health department.
for the,
Yeah, I thought you
for
said
the,
CDC
for
was
the
keeping
DA,
40% away.
for DHHR.
Okay, that makes sense.
But we originally, they were going to disperse 40% of that to the local health departments. We were able to get that increased to 60%.
Uh-huh.
We were hoping to go all the way to 70%, but they didn't want to go there. There's only a couple states that have done that, and that's Colorado and Utah and a couple other states that have passed through 70%. So that number comes in at for us using the state aid formula, comes in at $277,000 to be dispersed over 3 years. So it'd be held in escrow. And then a third spent down each of the fiscal years from 24 to 26.
And that's not in
24,
this number.
That is also not in this number. I wanted to make sure that I was extremely conservative giving you this number. I'm not trying to scare anybody. I'm just trying to be extremely realistic that maybe they don't disperse that in a timely manner or
So that
anything
could
like
be
that.
ultimately, so if it's over 3 years, so that could be roughly 100, like almost 100, yeah.
Yes,
over
and that
100.
really closes the
So
gap.
that really
there.
does, okay, thank you.
Right, so but again, that has not been paid out yet. And we know that sometimes they sit on these grants before paying them out.
But this is
And
why
I know
we're starting
Dr.
this
Reedy has
conversation
something to
now,
say
so
about
we
it.
understand
Right, exactly.
this,
And
and we're not.
go ahead, Dr. Reedy.
Yeah,
I know you
you
have something to
charge
say.
you $5 for blood pressure.
Yeah, that's, we're hoping to close the gap by charging
I have
$5
to
for
say
a
word
headlights
case
check.
here.
If we can make $128,000 checking
Mason's gotta earn
headlights.
his keep if his grant runs out, so he's gotta start a social.
Mason,
media.
Mason earns his keep,
program.
He is an excellent young threat rep coordinator. It also gets a little bit interesting, because out of the Senate on last Friday, they passed a $2,300 across the board personnel salary raise, $2,300 across the
Oh,
board.
okay, good.
Now that hasn't been reconciled with the House yet. Hopefully we'll know today Right, exactly, because this is crossover day, if I remember.
No, we're in the final.
This is
24
the
hours.
final, yeah, so-
36 hours.
So your crossover day was last Friday, sorry. So this day, we'll know hopefully by the end of this day, whether or not that goes through or whether or not they've reconciled it with the House, which was a percentage raise. And the reason you understand why the Senate would say maybe 2,300 versus a percentage, because the people at the top make
Yeah,
make the biggest
I got
raise
it.
and all that, yeah.
And it'll run right up until midnight tomorrow.
So I did recalculate that number, that 1064 using that, because roughly we would have about the same salary in fiscal year 23 as in fiscal year 24, but across the board, $2,300 raises it almost about 50K. So I included that. Now they will add a little bit to our state aid to cover that, like they did the 5% across the board last year, but because of the way state aid works, it's not the full amount for the wealthier counties.
Right.
So.
I think, I think your thinking on all this is spot on.
Thank you.
I'm looking at the 5 years. From 2016 to 2020, prior to you being here. And I'm looking at, I mean, were these balances at the very bottom line? Were those the budgeted balance?
Those are the actuals.
Those are the actual,
Those were
so
actuals.
how did this agency survive $750,000 worth of deficits?
Okay, that leads me to my next subject.
Did you get prompted?
Yes,
It's flowing so smoothly.
so,
I was, well, go ahead.
no, go ahead.
I was gonna say to that, to Ellen's point,
discussion.
I would love to see for context as what were the final budget over the past couple of years?
This is it.
No,
These are the actuals.
Yeah.
Those are actuals.
Yeah, I'd like to see like where
What
was
was
the
the budget?
approved budgets for
So
the.
they all zeroed, pretty much every had a zero.
Yeah, I think they
So
all
come out
zeroed.
Flat,
Right.
but it didn't.
They're very relevant to what you say.
Okay, so we budgeted, those were budgeted right
Close.
about. Got
Close,
it, okay,
close.
all right, that's helpful.
No, they were zero
Yeah,
budgeted,
they were budgeted.
and then they
in
ran a
balance.
huge deficit.
Right, there was gonna be
This
no.
was a zero budget right here, and they still ran a $307,000. You weren't here either.
I was here starting in 2018, yeah, so, but, yeah.
Okay, that was a pretty big deficit.
So before you go on, the $2,300 salary increase is across the board with every employee.
Every permanent employees only, not part-time temps. So they have to be permanent, they can be part-time permanent or full-time permanent, but permanent employees, of which currently we have 16. So
And how does that number relate to the salary increases that we've been sort of incrementally giving?
it's less than,
That's what I thought.
Yeah.
So technically, there could be a larger salary increase.
except for the
than
people
this.
on this will be for office assistants and things like that. This will be more than what they received
Right.
in the last year across the board raise, which was 5%. So this is significantly more, about $600 to $800 more for people
On
at the
low
lowest
end.
pay scale, yeah, lower part of the pay scale, yes.
Among the discussions, just so you don't think people are getting rich, this may pay for their increased PEIA health insurance.
Yes.
Yeah.
Now,
It's out of pocket.
now,
No, but it's a,
no need to get political.
no, but it is one of
That
the
is
things
going
being
on.
discussed
Right.
is that for those who rely on this job for their health insurance, that's a major factor that not everyone here is getting PEIA, but it's a significant piece because that, well, I guess in every industry,
I was gonna say,
Well,
private
it's going
insurance,
up.
insurance is going up for everybody,
Yeah.
so it's.
Absolutely, health
It's
insurance.
employer covered here for self only, so that's gonna be an increase to our.
I figured that in there. So I figured
Which
the
is a great
increase, the
benefit.
increased PEIA in there also, and obviously if we're making more contributions to salary, we're making more contributions to pension, and that's also in there.
Right.
So. Because 16 employees and $2,300 does not add up to $50,000, so.
yeah,
But
it
that's
would be
the
the same
increase
if we had Blue Cross. or
Right.
the county
Exactly.
thing.
Yes, so that gets us to what Elliot was leading us into, which is in fiscal year 2010, at the end of fiscal year 2010, Jefferson County Health Department was sitting on more than $1 million in the bank. So they had run a surplus in fiscal year 2010 of $280-something thousand and run several surpluses of six figures or more in the previous fiscal years. So the county commission saw that, they looked at that, they said, you're sitting on $242,500 or over $1 million in the bank, you're receiving $242,500 in county aid. They cut it down to $50K in fiscal year 2011, they cut it to nothing in fiscal year 2012. So up until 2010, we were receiving six figures or more, six figures roughly from the county in county aid. It is actually incumbent on the county to provide under chapter 16. It doesn't say you can, it says you shall, which it reads as must.
Right.
Provide financial support for the operation of the county health department. Says it specifically in chapter 16. I went before the county commission. I explained to them that the $242,000 would help us close our budget deficit. A restoration of what was given back in fiscal year 2010 would be the correct thing to do. They asked why I wasn't asking for more. I said I thought that just restoring what we used to receive would probably be appropriate instead of asking for more. And they were receptive to it. They're often receptive, and when the behind the scenes discussion happens, things can change. So we'll see what happens. Commissioner Tab was the only commissioner that was on the commission at the time that this was done, and she remembers a bit of the discussion, and it was mostly in and around the fact that the health department had this incredible amount of money in the bank, and they weren't using it to spend down programs. And that's where you get all these fiscal years. They ran a budget deficit I think they ran a budget deficit every year after that until 2021, spending down that $1 million. So that's where the money came from.
And we were told not to come back till we had balanced our budget.
Yes. So now that we've balanced the
Way to
budget,
overcorrect.
yes,
Just
a
kidding.
lot of that was, let's be honest, a lot of that was grants that were passed through for the pandemic.
So this 128 in deficit that you're projecting for 2024
Mhm.
could easily just be closed by
Multiple.
counties.
Yep, absolutely.
Okay.
Also, did we, remind me, did we put into a rule, did we make a rule or whatever the proper term is in terms of our operating reserve, the 3 month?
Yeah.
We voted as it, so,
You voted to say that we would follow state law on that.
right, okay. So I think that's an important data point.
Yes.
For the county commission.
And I included that in follow-up documentation. They asked for the previous 3 fiscal years,
Right,
accounting, my current year to date. I provided them that. I also provided them a clear explanation of what had occurred in fiscal year 2010. And did a little forensic auditing on the books from that era to find out, were we providing just an incredible amount of services,
right,
and we were just racking up the clinical fees or the environmental fees? No, we were not. We've raised those by, environmental fees have gone up almost 300%. They've almost tripled in the last like 12 years compared to 2010. So it wasn't that whoever the staff at the time, and I'm not bad mouthing anybody, it was very difficult to staff when you were paying sanitarians $24,000 a year at that time, and very difficult to staff. So they were not able to get out into the field and raise the fees, the environmental fees and things like that. Really what it was is just a lot of services were being undone. They had a very low staff. They had a lot more state aid and county aid. They were receiving almost $700,000 between the state and the county on an annual basis.
sure.
And
Yeah, I
their personnel costs were roughly $300,000.
Yeah, I think beyond I think numbers are obviously the data is
Yeah.
data, but I think from a practicality and operational standpoint is just, again, that 3 months, we're operating under a rule of 3 months, which is consistent with state. Because every agency, like even in the state level, and how bondholders look at, county debt and all that kind of stuff, you still want to have some element of operating.
Yep.
some time frame of operations. So typically 90 days is about standard.
Yeah.
And so I think it's just reminding them of that. think
And
is
I
gonna
said
be
that our,
important.
our reserve averages is what I said, usually it runs anywhere from $340,000, about $390,000, depending on the quarter. And that we have to have that in the bank. And so that's, you can't count that. So really, we're about $100,000 or $80,000 above
Right,
in a surplus in our account.
Right.
That's it.
exactly.
So
When did you have that discussion with the county commission? Was that recently?
it was 3 weeks ago.
Excellent.
So it was on the date on what date was that? Was it it was the 28th of February at 12 o'clock. I was there at noon. And it worked well. I gave a nice little PowerPoint. I'd be happy to share that with any of you if you want to see it. And a little speechy, and then fielded questions for about 15 minutes, and they were more than polite.
And isn't their budget voted on within the next 2 weeks, because it has to be into the state by
March.
end of March?
Yep,
Yeah.
end of March. And so we'll know no later than the 15th of April.
Right.
But I think I'll get grapevine before then. I
Okay.
think someone will let me know.
I think you'll know by the end of the month.
I think so too.
And one of the questions is, how do we not get in the same situation of suddenly having $1 million
Oh, that won't happen.
sitting in a bank account? And I think that has to, and I, similar philosophies in that, our role isn't to be bankers. Our
Right.
role is, if we get money to provide public health services, that's what we should do. Keeping enough aside that we've got a cushion that if there's an emergency, we have some money in the bank to hire extra staff. We can hope for volunteers each time, like a couple of years ago, but that's not a business plan.
But I'd like to I'd like to share sort of my philosophy on this, and that is, I think it's important to have the operating, 90 days operating in the bank and in reserve. I don't believe that if you have a surplus one year, you all of a sudden ramp up programmatics and you ramp up staff, because then it's like, when that dries up, now you gotta cut a program, you gotta cut staff, or, oh, we can't do that, right? So I'd rather see, I think, maybe a little bit more of a conservative approach, and that is maybe rolling over the excess into the operating cost for the next year, so that we can either give raises if we're able to, or we can keep costs stagnant, especially if inflation continues. So we have that, we continue. I'm not a big fan of like, hey, let's go do more stuff that then is not sustainable. I'm not saying you don't invest in new stuff, maybe moderately, but I'm just gonna share my philosophy on the front end of it.
I would make any of my decisions based upon like a 3 fiscal year average.
Or
Or maybe even a 5. I wouldn't
I agree with Karen.
I wouldn't say this year we're, running 100,000, we ran a, $100,000 budget in fiscal year 2023. So that means we need to spend another 100,000 in 20. I wouldn't do that. That's not the way I would look at it.
And always the biggest cost is personnel.
It's always personnel.
So
80% in this
when we
office.
So there are some administrators who say we're only gonna hire part-time people because we bring them on full-time and then we let them go, then there's this.
Yeah.
If we let someone go because we don't have the funding, it's a legitimate reason. If
But
we
it's
let
still not a
someone go.
good look, like, I mean,
It's terrible.
it's a
But-
terrible look. I
but
don't
it's-
like,
But
yeah.
people understand, I mean, this happens in other areas.
Yes.
I mean, for county positions, if the county says we're not supporting that department anymore, then it disappears.
Yeah, but it's not, I'm sorry, it's not that easy.
It's not that easy,
People aren't
but as
okay with
opposed-
it, and it is an issue, and if somebody, if it's an important piece, if it's like, oh, now we're gonna shut down sanitarians, which obviously we would not, because that's mandated, but like there's multiple impacts. So it isn't just like, oh, everybody understands, it actually isn't
Yeah,
that,
it's reputation.
It's
I'm not gonna work
reputation.
For the health department, they're just gonna lay me off in 2 years.
right? Or it's
Yeah.
like, why'd you lay off Brandon and not, Mason or
So,
Devin, like,
so as we look
sorry, I'm not
at,
taking on you, so sorry. Nathan.
but as we look at the social worker and the recovery coach. They, we've talked to some people and they understand that this is dependent upon funding for that.
Well, that's a grant, that's different.
Right.
We're
But
talking
even if we
operation.
brought them in as a full-time person, employee, they'd understand that that they have their rights as an employee, but also if we can no longer fund that position because we don't get the funding, as opposed to other people that are, we would want them cross-trained and things like that. So we're, but we don't want excess staff here. You know,
I was, so you can always write to the county commission in support of restoring the previous funding to the health department that they cut in fiscal year 2011. Feel free to do that. If anybody likes, anybody listening, feel free to do
Was
that.
the amount 242?
242,500 was the original number, that
That's
was,
what
that
we
was the
requested.
last, yeah, and I just asked, I requested just a restoration only.
Is that what you asked?
I asked for $242,500, just a restoration of the previous funding from 2010, not inflation adjusted, nothing, just.
Did
flat.
anything in that conversation come up about, cause I mean, I know when I first joined the Board of Health and having initial conversations. There was a bit of a perspective from the county commission that, well, we give you this building, you don't pay rent, we pay your electricity.
That was
That's
not-
enough.
That was not discussed in any way. I think I made it very clear that their requirement under chapter 16 is that they shall provide funding up for the operations. So operations funding as opposed to in-kind funding,
and that they will provide this.
and that they will provide facility. Yeah,
That's in the code as well.
no, that is not in the code, but that is common, that's common practice throughout the state.
I think it's in the code.
It may be in the code a little bit, but it's not obvious. But yes,
So are they interpreting the support of the building as operational
Yeah.
support, or are they
That's-
just?
Well, they
that's
have,
saying it is.
they have in the past. That
Got
is,
it,
that has
okay.
been the response when they've been asked before.
That's how they believe they're meeting the state statute by providing the building.
Well, kind of, sort of.
They know that they're in.
They know that they're not,
That they're not.
but their budget's been tight, so
Right.
that's the excuse they've been using. And again, we've been spending down this surplus.
Right.
Okay.
And I can understand their perspective 100%. I mean, if the health department was sitting on $1 million.
Oh, sure.
After receiving, nearly $250,000 from the county, they're thinking, you don't need that money then.
And were you here at the time?
I came in 16.
Oh, okay. It must have been an interesting time.
Sounds
So-
it.
So I'm hoping that we have that restored. That would definitely put us very nicely. Moving into fiscal year 24, fiscal year 25, fiscal year 26. That's really my goal. My goal is to put us in a position where we have an idea of what our funding stream looks like moving forward and at least a solid portion of it. And that comes through state aid, that comes through county support. And that's the longer term goal, is to make sure that those things are in place and steady going forward. So.
And the
Um,
reasons that those salaries were so low at that time was we couldn't keep anybody here because the salaries were so low.
Yeah.
The big change came when we got some increases from the state.
They were still severely understaffed when I started in 2018.
Yeah, was that the year that they went to Charleston and got the
Yes.
increase? Yeah,
Well, we got the increase for the sanitary.
yeah.
Yes.
But also remember, the state hit the skids financially in 2010. When the coal and natural gas guys got hit.
Yep.
So our recession actually started in 2010 and carried through probably till 14, 15. Versus the rest of the country that was 2008 to 2012. We were on the back end of it, so. That also kind of matches up as to why there was kind of a non-activity at that time in terms of raises, et cetera, et cetera.
Yep.
Because of the financial situation with the state.
I do foresee consistent pay grade range increases from the state to the Division of Personnel. I also see across the board raises probably being an annual thing for the next few fiscal years, because the state is having such a difficult time holding on to employees. And it's when exit interviews are done, the number one is
If they're-
salary. It's pay.
If
It's
they're
always
gonna
pay.
mandate certain salaries, shouldn't there be what they send in terms of the funding of this agency also then change, so it's not.
Yeah,
unfunded?
so I do see state aid increasing. I just don't know what the number is, so I've kept
Right.
it flat.
Right.
I can't just say, I think it's going to be some magic number that I pull out of my head. It's just.
When will you find that out?
So hopefully I reached out to the director of the Center for Local Health and also to the president of the Association for Local Health Departments, and she said I was the very first one to ask.
Oh.
And I said, that's because I'm doing my budget a month or two ahead, and she says, I'll get back to you. So hopefully I'll have an answer next week. And from one or both of them, and the sooner I can get that, the better, and then I can give you a little bit more firm number. I do see, you see that the next week, or next scheduled monthly meeting is April 14th. That's nice and deep into the month of April, so we should have some much clearer numbers on that and leading into the vote on in May. But you guys can rest assured that the numbers I'm giving you are extremely conservative. And that's the way I want to run it. I want to run it where I think things will cost a lot more than they probably will, and that we won't get nearly the revenue that we probably will. That's the way I'd like to do it, and that way we can smile and that we actually did run a surplus when we expected probably a deficit.
Hope for the best, prepare for the worst.
Absolutely. I was in customer service for a very, very long time. It's always, under promise and over deliver if you can.
So the main ones are the changes, the state aid
Mhm.
could change this,
Mhm.
the CDC infrastructure grant.
For the
could
other
change-
grants, yep.
Could change this, and then the continuation of the threat prep grant.
Yep, that would be, yeah, that is pretty much zeroed out in this
Uh-huh.
budget, but if we lose it, the personnel costs
Okay,
will
so there's no
change.
upside, but potential downside.
Potential downside on
And
that.
the line that isn't in here yet is the county commission.
The county
Oh,
aid,
yeah,
yep,
county-
and county aid.
So those are kind of
That's
three big ones.
Yeah, and those are the big ones. There, one negative and two big positives,
Okay.
so. That's where we are, that's where we stand, as of right now,
Thank you.
a very conservative deficit of 128,000.
So you cut it in half from last month, so when we come back next month, we'll be cut in half again?
I would like that. I'd like it to be a zero balance
Even better.
projection. That would be the goal.
So the projected $70,000 surplus from this year is not also figured into that.
That's just in the bank account.
Okay,
That just sits in the bank account.
We have the
And we
ability to
don't
roll
even,
that over, so.
right, we roll that over and we move from there.
Right, thank you.
Okay, good update.
All right, moving on to the agency activity reports, environmental.
New format as well, huh?
Fine.
Good stuff.
So this, between the three sanitarians, they did a total of about 144 inspections and soil evaluations last month. So it's a little increase from January. We had a little less training last month, but we did have a mock foodborne illness outbreak investigation one day last week, 2 weeks ago. And that included participants from the industry, local industry, state, CDC and FDA. So, and all of our sanitarians were able to benefit from that. So if we don't have an actual foodborne illness outbreak to investigate, we're supposed to do a mock investigation once a year.
Right, first I thought you said you've had one, I was like,
No. it's
can
a
we
mock.
find out where it started?
No.
Please.
So, our new sanitarian's about halfway through his training right now. We sent one of the other newest sanitarian prior to him to a certified pool operator course. And we have been updating our web page and applications because of the new credit card online billing. So all of our applications need to be updated. So Patty's been spending a lot of time working on the applications. So, and we did change, I guess our page is now environmental health instead of permits and regulations, and everything else is still the same, but the link changed a little bit for our page. We spent earlier this week, we were dealing with the boil water advisory from Charlestown Utility Board. So that the notification for it, I was told by the director of Charlestown Utility Board that the notification system uses billing numbers for that. So the majority of our food establishments were not aware of the boil water advisory, so we spent all day on Wednesday
making phone calls and answering questions and everything else about the boil water advisory. Thankfully, found out, that the water sample came back clean, so everything was fine, but that did not go the way it should go, so. So there were a lot of people that didn't get notified. There was a lot of confusion about who was impacted, so.
Yeah, there seemed to be like everybody got the end of the notice.
Right,
The consumers did, but I just heard this from consumers, but they didn't get the FYI, there's a boil notice.
Right.
So,
and we were just notifying food establishments, so we
Okay.
spent the day doing that, so,
gotcha.
so that was.
Have they figured it out for the next time?
I
This may
don't
happen?
know, that it's up to Charlestown Utility, the board to figure out what, I think that what they need to do probably is reach out to the establishments and make sure they have a good contact number for those boil water advisories. So when that automatically goes out, it goes to everybody. We were hearing from a lot of consumers that they didn't hear anything either, just.
Yeah. That's where I heard it from.
So. Yeah,
We hear it very quickly in Harper's Ferry,
yeah,
because we get an email and a phone call.
right,
And we've been known to get up and go to the ambulance to shut off the ice machine so that it won't keep on dropping something and we have to clean out the whole
yeah.
thing. I mean, we've been known to get up, whatever we were doing, if we were closed that day, and go immediately to turn that stuff off.
Right. Yeah, I said this was it impacted, like, they were saying that the impact was all of downtown Charlestown and all of Old Town Ranson and maybe even some outlying areas. They said it was hard to determine exactly how far it went. They go based on loss of pressure, where that's reported, so. So yeah, we were just basically calling all the establishments in Charlestown and Ranson, so.
Is that the first thing you tell the restaurants to do, is to get that water shut off inside their establishment?
We tell them that they shouldn't be using it
Yeah.
for anything other than maybe hand washing if you're gonna sanitize afterwards, but for everything else, for food and washing dishes, you shouldn't be using that, so. So that's what we tell them.
Yeah.
So, and we have some establishments that can't really operate when they're on a boil water advisory because like coffee shops, all of their stuff is plumbed into the water line, so. And
Yeah.
they have filtration units, but that doesn't.
Yeah, we shut off the water valve to the coffee because,
Yeah.
we can go make some.
Right.
And do a pass through, pour through
Right.
of what water we boiled. But we shut it off to the ice machine and the soda machine
Yeah,
so that none of that will get in the lines and we have to flush it. If somebody goes in, decides to
yeah.
hit the button.
So,
But we,
yeah, I posted it on Facebook and I sent out a mass email to the establishments that we have email addresses.
Yeah. we learned that lesson the hard way when the ice dumped when we weren't there and it's all brown and we have to clean out the whole thing. It was
Yeah,
a mess.
yeah.
Brown ice.
Brown ice was.
So
Like, thank you for
luckily,
doing that.
luckily
Yeah.
it came back clean, so.
Using,
Yeah.
the analogy, the glasses half full, the good thing is that it was recognized, it was responded to, we've got, communications always the issue, here too.
We did have a lot of people calling us asking why they weren't notified, but it's not our job to
We
get
had
a
a
notification.
discussion of threat prep with the regional emergency managers yesterday, and among the issues is they have a system called Nixle, which is a notification system, but I think they're less than 5,000 users in the county. So it's not really much of a notification system. It's not as capable as some of the other systems out there, and so they're looking to go to the county commission saying they need to upgrade it. The Nixle system apparently is going to be no longer supported by the owner of it in a year. So, but they need something that
Cause that's usually really good. I mean, I'm on that, I'm on the county one, it's
Yeah.
usually really good.
but it,
Of the county, but it only comes to my personal email. I
Oh, I
can't
get
get it to go to my
text.
phone anymore.
I get
so-
text.
Mine used to go to my.
But the public school, the school boards is hit or miss. Sometimes I get their alerts, sometimes I don't. Which like I had no idea the school was canceled this morning or delayed or whatever it was, which not that it matters to my.
Oh, really?
Oh, I'm sure Brandon knew.
You know, so I was like, I don't know why some stuff comes through and some stuff doesn't, because, you know, I was just keeping an eye on what's going on and if there's anything happening, especially a threat or
Sure.
health or whatever. Sometimes I get stuff, sometimes I don't.
So some of the more robust ones even have the opportunity to. So what if you're on a highway and the train derailed and there's poisonous gas, how would you know if you live somewhere else? But they can actually access cell phones by geography, even if you're not a user. And apparently that's when you sign your wireless contract, it allow your emergency accepting that. So that's something that's needed for lots of ability. How do you quickly notify people?
Yeah.
And that's hard to do.
I was thinking about that, like the Amber Alerts and things like that. I imagine that's a pretty complicated thing to get deployed, but if you just get an alert on your phone, if you're in an area that's under a boil water notice, that would be great. And I imagine that's not an easy thing to do.
So the one I have from Berkeley County, you can turn off some of the alerts, like the floodwater. I don't live in a floodplain and I don't want an every 2-hour flood alert through the night. So it's work, but hopefully that will be something over the next year that, because that would be something for public health reporting. We may want certain jurisdictions to go to notify.
Sure. Thank you. Threat preparedness.
So that was kind of what I was gonna talk about. But actually, whenever I went to that emergency management conference down in Savannah, they had a whole bunch of vendors there that were showing all the different options and the newer updated versions. And so I passed those along to our emergency management partners for Jefferson County. And so I think they're deciding which one they want to update to, since, Nixville is no longer going to be applicable. So
Cool. Is that it?
I think that's about it. Yeah. I can't really think of anything else. Yeah.
Any news on possibility of CERT training starting?
It's still a work in progress.
Which training?
CERT.
That's community emergency response.
It's teaching
It's
average
basic.
people how to do like triage
Right,
and CPR and stuff like that.
And basic like search and rescue, that sort of stuff.
Cool.
Yeah, the assistant manager is getting certified as a trainer to do that. So it is something they're working on.
And he has to go through Emmitsburg EMI, so those classes aren't offered very often. I'm actually going to one next week for public information training.
That's the FEMA home base training.
That's the FEMA home-based training, and it's only offered either at Emmitsburg or if they go out in the field and go to a state and offer it, and so.
Isn't there a community active shooter training at one of the fire halls coming up fairly soon?
I would have to ask Steve about that, but they always offer active shooter training down at Summit Point.
Right, the one that we all took,
The
yeah.
one that we went to. And so I have the contact, it's Nathan Harmon.
Right,
Sure.
but there's one, I think, at the fire companies this month, because somebody was telling me that they gotten an email, but I haven't seen that one.
Always worth going to that training.
Uh-huh.
I
Excellent.
I can ask Steve and I can send you that information.
All right, clinical.
Once the nurse director finishes her education, she'll be available for this meeting. I hope, if we don't lose her.
Lindsay?
That's Lindsay Gregory, yes, she's wonderful, but again, she's a full-time student too. We were in line on the clinical report. If we had a full month, we probably would have been fairly close to the 3-month average in most things. So I didn't have any problem with the clinical side numbers. They're doing a great job. They're also doing a lot more outreach, getting out in the community, doing trainings, doing vaccine clinics for like flu and things like that. So that's been very, very nice. But those are also things that we're going to gear up moving into fiscal year 24 is to be able to get provide more locations within the county for childhood vaccines and things like that. So we want to get out into the community a lot more than we have been able to over the last 3 years. So I know Dr.
Over
Reedy
the
has
last
some,
few months with the naloxone training they've done, they've gone to the different law enforcement agencies and provided training for them and supplying the naloxone at the local emergency planning committee meeting last month.
Yeah.
There was a presentation, and so some of the members stayed after, about 10 of them, and got training and supplied. They're going to one of the churches this Sunday. They've been invited, and I think they've got 40 people signed up right now to get it after a service. So they're
really getting out into the community, which is very nice. It's something that was one of my goals here, was to make sure that we improve our community relations and work closely with all the community partners, which we hadn't been doing over the last few years because of, we all know why. So being able to get out into the public was much more difficult 2 years ago than it is now. So we need to get out and do it.
and went earlier this week to Mountaineer Recovery, which is longer term drug treatment program in Kearneysville, Berkeley County. And spent about an hour, 45 minutes talking with their leadership, seeing their facility, what they have, finding ways to collaborate.
Yeah.
It's very weird having to turn this on.
We switched around.
All right, so this is just gonna kind of show you guys in the visuals then kind of what's going on in terms of COVID, influenza, all of that. So respiratory, this is kind of what we're looking at for the, let me see.
Yeah. I think it's better. There we go.
There we go. A little bit better. There we go. Okay, now you can actually see it. So this is looking at the respiratory pathogens that are seen in Jefferson County from December to March 4th. This kind of just shows the overall progression. From last month to now, there hasn't really been that big of a change. It's kind of just stayed pretty steady. Here we go. All right, influenza. So this is a weekly influenza surveillance map. So the week of like December 31st, it's that week. And same with January 28th, it's that week. It's kind of just a snapshot of like the flu levels that each state's seeing. Which all of this is on trend with the normal influenza trends. It might be a little lower than normal, just because, you know, now we have COVID to add into the mix. But so green down here is minimal, and so we've been green for the past 2 months. And then prior to that, we were still kind of in that low moderate range. Okay, so this is the positive influenza test reported by hospitals and labs. So these are the confirmed cases. As you can see down here, this is kind of, this is kind of where we're at right here. Extremely low levels. We had our spike, and now it's kind of leveled back down. And with COVID, it's a little bit different though. So obviously we're progressing in the right direction. We've been green for the last 2 months. Yeah, we're heading in the right direction. I will say, I know Dr. Reedy can kind of agree. There has been more hospitalizations in the last month. There's definitely been a spike within those values, which I can show you a little bit later in the PowerPoint. January, we were in the moderate level, and then the last February, March, we've been green in terms of the community levels. This is kind of just looking at the same thing, just number values. You can see the last like probably 2 to 3 weeks in that portion, it has been a steady increase over the last couple of weeks. And then along with that, that's also in hospitalizations as well. You can see that they're kind of up higher than we've seen in this time period. Traditionally. And then reportable diseases, so this just looked at all of the diseases that are legally reportable to the health department. These are diseases that we can, often can be traced back to certain elements within your community. So we have a decent amount of foodborne illness related diseases this month. We had 5. We had some hepatitis as well, some tick-borne, and some respiratory. And then the very bottom, we had 132 COVID cases that were positive.
Lyme disease.
132 what?
132 COVID cases that we.
COVID?
Yeah.
Lyme disease 33, that seems really high, especially this time of year when we're not outside.
So
Is it
we-
just the
we had
latency?
not- So we actually don't, we don't analyze them, and there are more reportable diseases. These are reported not by individual practitioners, although they should. That's it's mostly reported by laboratory tests electronically going from a facility to the state. We actually did not get those cases to evaluate because it's not like you're going to transmit it to someone else. The state gets it. And so we're not analyzing when were those people tested, when did they have that, so this could be late reporting of things.
Yeah, I was gonna say like
that
a
went in
latency,
before.
like they got bit in the summer and they just got diagnosed.
Right, or they may have been reported but not shown up on our dashboard.
Gotcha.
Again, because it's a low, it's not as if we're doing something, it's more for record keeping, but
Yeah.
traditionally, it's around 200 cases a year for Jefferson. We know it's here. Yeah, we just do keep that.
So the flu is back, because with the onset of COVID, the flu like all but disappeared, and now it's all of a sudden it's back. So
Yeah.
what's up with that?
We've just been testing for it a lot more.
Oh,
Yeah, it's,
Well, so even more than a year ago, that if you went to the hospital or most of the urgent care clinics and you got tested for COVID there, you were getting a 4-plex test that also tested for influenza A, influenza B, and RSV. But until this fall, we didn't see many of the cases of those others. And the thoughts are that because this was worldwide until this past spring in the Southern Hemisphere, Australia, the cases again, but by that time, the mitigation measures to prevent respiratory viruses, which included all the things that interrupted our normal activities, those have pretty well stopped. So it's going to be interesting to see that whether there is a second spike. So we could get another flu peak this season. We're not out of the season yet, but we're getting close. So I hope not, but I see that they're having a bit of a surge in flu in China now, and they've stopped doing the COVID testing for Chinese. So we'll see if we can't control what happens to some of these things, but it is worth watching. Another comment on foodborne illnesses is relation to the training. The state told me that last year they only had 1 foodborne outbreak, and that's, and we're skeptical that that's true. It's just there was not reporting. So most people that get some diarrhea or nausea or vomiting, they don't end up going to the emergency room for it. They're better in a day or two. And certain things like norovirus aren't even reportable. But if there are outbreaks, they are. But that is something we want to be paying much more attention to, is that if there's a source where people are getting infections, we want to know. These are mostly self-limited, but some things like cholera aren't. And we're not immune in the community from having this, especially if there become, breakdowns in sewage or floods or something like that. So.
and once it starts getting warmer, usually reporting this start creeping up a little bit. All right, are you ready?
Okay. So I'm going to talk not specifically about the opioids. The next slide, as we discussed the last two times, the opioid deaths and the use of opioids, and fentanyl in particular has gone up next. These are some things I want to talk about is substance use disorder, intravenous drug use, bloodborne pathogens. Bloodborne pathogens, mostly we think about hepatitis B, hepatitis C, HIV, syphilis. Those are the common ones. We don't have to deal much with malaria here. In some parts of the world, that's an important problem. So harm reduction program, which also includes a syringe exchange program. Those terms are often used interchangeably, but they're not exactly the same. Next. Hepatitis C has increased greatly over the last few years, and that these are acute cases that and that goes along with intravenous drug use going up next. And the number of hepatitis C patients that it's related to drug use has gone up in this sense. I think in 2018 was the year it got cut off there, but 18. But that's continued to go up even higher. And in some places, the incidence of hepatitis C chronic infection is so great in the community that it used to be that if you were an IV drug user for next slide, for 5 years, you had an 80% chance of converting to hepatitis C infection. In some communities, there's so much that if you share a needle, almost anyone you share it with has hepatitis C. So your chances, you don't need to wait 5 years. It's likely within a year. We're not quite that bad yet, but the screening is it's mostly young people. Just a few years ago, they talked about the at-risk. The greatest group that needed to be tested was us boomers, because maybe it was because they got multiple injections when they were in the Army. We weren't sure exactly why, but that's no longer the case. It's now the young people who are experimenting with drugs. Not as many new cases in older people. They've had their risk and they've either gotten it or haven't. So the screen all adults at least once. We actually in certain age groups, regardless of guidelines, will want to screen more depending on risk factors and things like that, and pregnant women. Next. So those who haven't heard, you'll probably hear this again. Scott County, Indiana in 2015. It's a small county, as you see, population of 23,000. So it's a little larger than Morgan County, much smaller than us. In the city of 4,000, suddenly had about 180 cases, eventually went up to 200 cases of HIV. It was slow in being detected. The one place that they were traditionally doing HIV testing was a family planning clinic that had closed, but it was clearly related to intravenous drug use and prescription injectable that had been diverted. So this was not fentanyl, it was drug use. It doesn't matter which kind. Eventually, after figuring out what to do about it, they opened a syringe exchange program. They didn't earlier because it was against the law in Indiana. Finally, Governor Mike Pence, and Jerome Adams, the state health officer, who later became the Surgeon General of the U.S., they did get the legislature to authorize limited syringe having certain criteria. And calm down. Next. After that, there was a study done saying, well, which counties are at risk for this? And they looked at number of hepatitis cases and amount of intravenous drug use. And these are the counties in the US that were considered at risk. And you can see there's a nice green area over Appalachia. And this is West Virginia. So among the top 200 counties are also Berkeley and Morgan. And that was, saying that these counties are at high risk for getting an HIV outbreak. And interestingly, a few years ago in 2017, there was an outbreak of hepatitis A, which was usually considered as a foodborne illness, but it involved the homeless and intravenous drug users in San Diego, but then it became a multi-state outbreak. And in the next 2 years, traditionally in the US, there were only about, across the US, about 2,000 cases of hepatitis A. But in West Virginia alone that year, there became 2,000 cases. Half of them needed to be hospitalized. Most of them were intravenous drug users. And it looked very similar to this map is where they occurred. We had very few, maybe 5 cases in the Eastern Panhandle. So that continental divide helps. It does change patterns. Where our drugs come from is different. So we saw that happened. That got better. But fortunately, hepatitis A has a great vaccine that one shot gives 95% of people immunity. So that was something that could be stopped next. This is so Cabell County and now Kanawha County have had outbreaks similar to Scott County. The number of HIV cases in 2020, as you can see, 139 of there were 139 new diagnoses, and most of them were people who inject drugs. That's the PWID. Next. That second set of graphs is from 2016 through 2020. That's how many cases of HIV were due to intravenous drug use, and you can see it went from a very few to higher. So that's the predominant mode of getting HIV now. Not that sexual transmission is unheard of, but that's so it's an issue now, as had been unfortunately predicted. Next.
Is there some correlation
Yes.
though, because you have the preventative drugs too with HIV, which a lot of the gay population tends to use, especially the male gay population.
Yes.
Homosexual population tends to use. So is that also a correlation of that trickling down?
Could be. So it could be, and I hope that's even better. We do offer the pre-exposure prophylaxis or PrEP here, and our nurses are really good about advocating for that. Not as many people use it, but we hope that that's going to get less and less. PrEP is available for people who are intravenous drug users. That would be one of many services we could offer to such people. Unfortunately, we don't have a vaccine. We have medication that can help prevent it, so that would be one thing. The trouble with HIV, although we have great treatment for it compared to early in my career, it's lifelong. And next. So this is information from a recent conference I was at that the CDC was out in Kanawha talking with them, and they had four cases, 4 clusters in the US that were worse than what was happening in Kanawha County. One of the 4 was Cabell County, so 2 of their 5 clusters. The other counties had populations over millions, so, and these were not these were not rates, these were actual numbers of infections. So we're at high risk. Fortunately, we are not part of these clusters. The behaviors aren't much different. Next. So that's just what I said. Their case numbers in Kanawha are, as of a couple of days ago, we're up to 100 now. Next. So syringe services programs or syringe exchange or needle exchange. And the other term is harm reduction. Harm reduction is other parts of it. So they're used interchangeably because syringe service programs next need to offer a bunch of different services. So these are the kinds of services next. So I'm going out on a limb to start talking about this. We do not offer it here. They do in Berkeley County and Morgan now, I believe.
What, the syringe?
The syringe exchange.
Is it done at the health department there, or is it done in a more central?
It's done in the health department and also mobile. So, and those aren't mobile like they're going house to house, they're going to sites. And that's all.
You know, their health departments in town, sorry, where are their health departments located compared to ours?
It's not easy walking distance. It's in Martinsburg proper. It's on the west side of the expressway, and the Pan Tram does go there, which does help some, but it's for most people, they need a vehicle to go there. But it is near the population center.
What does number 6 say? There's something covered.
I'm sorry.
Just read it. What does it say?
Syringe collection. And it's shared. So what it means is that when people come, people come to get syringes, they have to bring their used ones back. And it has to be a 1-for-1.
I can understand
It
what it
was
is. I just couldn't read what it said.
Jefferson County a few years ago.
So it was tried. It was not the this kind of model. It was much more giving out the syringes. So it was an outreach, but it wasn't as formal as this.
And I don't remember it being very successful. Is that?
Well, one of the difficulties was measurements were not taken, so there wasn't data collected to be able to measure effectiveness. So it was effective, and it did get a lot of syringes out there. One of the biggest concerns is that the two big concerns. One is that if you give them clean syringes, you're going to promote the use of it. Unfortunately, that's if it was that simple, people wouldn't use. But if you have a compulsion, if you drink alcohol, you don't need a clean glass for it. If I get near a refrigerator, I do not need a fork and plate. You know, it's nice if you provide them, but it doesn't really encourage me. You not watching encourages me. So, and then the other is that there's going to be syringe litter. And that's a valid concern, but just like foodborne illness, when people are reporting it, depends partly on, are they sensitized to start reporting it? It's hard to know when people are against harm reduction or syringe exchange programs, they say, oh, now there's all this syringe litter. It's going on in most communities. One of the hopes of these programs is actually to reduce syringe litter by having people bring it back and give them counseling about it. Most people do not want these around. Next slide. And this is the other one. So it's education. It's doing medical. So these are, for example, medical treatments we could do here. This is a group that they do not want to go to hospitals. Many times people are not treated nice in healthcare facilities, and there are various reasons for that, but they can be a tough group of customers. Practitioners, nurses who say, we understand the issues here. We're not going to freak out every time they aren't polite to us. So doing some basic medical care is important.
On a substance abuse treatment, you talk about this potentially being a service here. Are there grants available for that?
So there also is to get the substance abuse treatment, you pretty much need your medical card to get, whether we offer it or someone else. So you need insurance. Most of the time it's Medicaid. But that is something we can do. I have what's called the X waiver, which is an additional DEA license to provide buprenorphine. They have now gotten rid of the requirement that people have that. But we can do it so it's a potential revenue source. There are many of these programs in substance use that are they're not for profit, but they're making a lot of money. And recovery houses or whatever, and so that wouldn't be the goal, but it would enhance it would enhance our financial bottom line. More importantly, it's an unmet need in this community.
I guess the other question I have is there an opportunity for, like, first of all, is this legal in West Virginia? Are we allowed to do this?
Yes, and so that'll be the next slide.
So, but before we go to that, is there an opportunity for, like a partnership from a locality? Sorry, I keep going back to sort of where the population center is versus being out here. So is there the opportunity for us to partner with like the Jefferson County ministries or a church, or, you know, again, from a locale standpoint?
Yes, and that would be so I'm bringing this to go out on a limb. The problem with going out on a limb, you just worry it's going to get sawed off, but that's my job, is to go out on a limb. And that's our job, is to say, why isn't this being offered? Because it's not easy. But yeah, there are community partners. That network has to be formed before Berkeley. So when I first joined the Berkeley Health Department, they had been exploring this for about 2 years and building a partnership. My first month there, they opened their first day of having a syringe exchange program. It built slowly. Now they're seeing about 200 distinct individuals a month for it. But yes, one of the problems they had here offering it is that the state police cars going past and parked at the end of the driveway make some people a little nervous. Finding, we'll go further so to provide this, and I can send everyone the both the law, the code, and the legislative rules that go along with syringe exchange programs as current as last year. I don't think there are any changes in the laws this year. So we have to have a majority of the members of the county commission. So since this became law, there's several counties that were offering syringe exchanges that had to stop offering it. Cabell County is very worried because they have had one of the HIV outbreaks, and they're a leader in this. Because it's 3 votes instead of 2 votes, whether you can have it or not. But also the municipality. So if we partnered with somebody, you'd have to have the municipality agree, and that even if it wasn't required, it's just common sense that if the mayor says we in the council and the citizens don't approve it, so there has to be a recognition that there's a need. It's something that hasn't been discussed a lot in open forum, but prior to COVID, this was the #1 issue. It is again the #1 issue as far as decrease in longevity. One of the biggest reasons is younger people, meaning 20s, 30s, 40s, especially, are dying. And when you lose someone in that age group, it has tremendous impact. It's also, it's workers who aren't available, but it's also parents. So there are many children who have lost a parent. Currently in the county and in the nation, big statistics on that. The COVID fortunately did not affect the young much. So next, but it also can be suspended, as I mentioned, the other counties. So if we have a 3-2 decision and a county and municipal level to permit this, it can be stopped quickly. This was enacted at the state legislature a few years ago, when there wasn't that requirement. So the next. Is that it? Okay, so it's something I'd like us to talk about. This is a limb to go out on, but really need support and direction. Is this something we want to be involved in? I think we need to be involved in. There is not any other leadership organization coming forward in this county. Berkeley County Council was very involved. They you don't really want to compare others, but the county government support has been essential. The syringe access and their quick response teams are actually staffed primarily by county employees, not health department employees. The monies come through the health department, but they contract with these recovery resource center in Berkeley County. EMS needs to be on board as far as referring and others, but there is the partnership, but it's a big deal. It's not in any line items. This would be grant funded. The grant cycle usually comes around, in the summer. So if we were to go forward with it the next year, we need to apply for it, in the next couple of months. So that was part of my presentation. It's not an action item today. But
Thank you for that. No, I mean, from my perspective, I think I need more data in terms of, what is the cost? What are the number of individuals or ratio of individuals that we're going to be servicing? And then honestly, a stakeholders plan of who are we bringing on board? How are we going to do it? I think before I could support, for me, I think for us as a board of health, I think we need that information. And I think also if we're going to try to get a commission, the county commission, if that's what the decision of this board is, then I think we have to have all of those ducks in a row well before we pursue anything like that.
It's kind of a chicken and egg. I mean, maybe if the county commission were to act on it first, and what their position is on it before we spend too much time.
They probably need data.
they would be
too.
interested in the same information.
Yeah,
Right,
I think they would need that
exactly.
data there.
And there are, though I have knowledge of this, there are people who are intimately involved with it and have the numbers. There are people in Berkeley County, Gino's counterpart in Berkeley, can talk about the expenses. It's pretty well all paid for by the grant. And I anticipate further money through these, at least for a few years, from these pharmaceutical company settlements, but taking care of people with, and there are a lot of economic data about, what happens if you are using, if you get hepatitis C, if you get HIV, what's the cost, who pays for it? Well, the community, one way or the other, we end up funding it. Does it increase bed availability for other conditions in your hospital? Which is certainly an issue for our counties as we have a growing population that grows faster than the hospitals and school systems can.
But if they're seeing 200 in Berkeley County with their population being double ours, we might see 100 if we had a facility to do this too.
Right, so there are different ways of doing it. At the start of COVID, they were only seeing 100. And rather than decreasing when they shut their doors, they figured out how to do it in the parking lot and to start doing mobile. So their numbers actually increased. And some of that's as word of mouth got out and there became greater comfort. And they expanded the amount of services that they could offer. There are lots of different models for how to do that. We would have to abide by the state model.
How often do they do this? Once a week?
They do it once a week in the department. And then on different days, they have the mobile. I think how you would do it, it depends on your capabilities, what the need is. Once a week is not ideal. That people can't all, especially because many of these people actually do have jobs and they do work, and if the goal is to try and offer services to them, ultimately it's to not simply give them clean syringes and other paraphernalia so they don't get infected, but it's to help them stabilize their lives and get off using street drugs that are a problem. It can include going to facilities where you get clean, or it can include switching them to outpatient Suboxone, buprenorphine, or other treatments. So there are a lot of things that each person's different, and when they are ready to do it, you can't just say it's time. Sending them to jail, some people that helps, other people it doesn't. And so nobody has an answer that fits everyone, but you want to help. This affects all segments of the population. Thank you.
Any other questions? Administrator.
So first of all, I'd like to thank Dr. Reedy for actually having the guts to do this, to bring it into a public forum. Most people don't. It's easier to sit back and pretend this doesn't happen than to actually try to address it. So thank you for that, Dr. Reedy. Also, earlier, Elliot, you had said that the numbers have improved since I came on. I have to give credit to Gillian. Gillian was the administrator in fiscal year 2021 when the first big surplus hit. Let's make sure we give credit where credit is due. So staffing, overall, we're fully staffed at this point. I have noticed a decrease in the time it takes for inspections and permitting. I know that Gillian has also. She's communicated that to me, but I've also been more involved on the environmental side to make sure I understand what's going on and how workflow and productivity is going over there, just to make sure I'm, have a holistic view of the health department. I've noticed a decrease in permit times and things like that. We don't get complaints anymore that things are taking too long. We don't get complaints that I haven't received an inspection. Don't have any of those phone calls or emails coming into my inbox anymore. So that's very, very nice. We'll continue to focus on customer service and reducing turnaround times on permits and inspections. And like we said earlier, we're performing more outreach events on the clinical side, including naloxone training and things like that. Great number here. We've received we've earned $86,000, more than $86,000 in clinical services year to date versus only $99,000 in all of fiscal year 2022. So we are trending ahead of clinical services revenue already. And by the end of March, we'll probably have surpassed all of fiscal year 22. So that's important because improving insurance billing was a goal expressed by the health officer and the Board of Health when I was hired. And it's something that has been incrementally improving. The clinical staff is improving their abilities and knowledge when it comes to properly billing insurances and understanding how that's done. And they're becoming much more proficient. We did contract with a medical billing company to help us capture some of the insurance billing that we were unable to capture from fiscal year 22, and that has resulted in more than $30,000 in billings that were about to expire. So being able to get that to the bottom line has been helpful. So that is part of the reason why we have a disconnect between our February numbers and our February bank balance, is that the checks are in the bank. They just have not been invoiced as paid invoices through QuickBooks yet. That's when you're receiving onesie twosies of $40 and $80 at a time. It takes time to input all that. And so most of that is in now, and we'll see that in the final February numbers. And one last thing. State requires, like I said last month, state requires that we have the ability to accept payments online. We've decided to go with online credit card payments. I will have the link on the website by the end of the day. It was required that it be done by the end of March. So we're ahead of schedule on that. And it's all allowed us also to take American Express, which we weren't able to take previously. And a lot of businesses like to use their Amex cards. So that's a very nice little
What
added
fee do we
service.
charge for that?
There is a fee. It's 3.99% that is passed on to credit card user. That's pretty standard for government agencies to pass that on. So instead of absorbing it, we were absorbing that previously. And that was hitting the bottom line to an extent, so to the tune of about 5 figures. Other than that, I'm sure everybody else has everything, other things to do at 11 o'clock. So I'm done.
Well, thank you. Is there a
No?
motion to adjourn?
Second.
All those in favor say aye.
Bye.
Thank you, everybody. We are adjourned.
Thank
Guys,
you.
have a good day.
You
Bye-bye.
too, Ann. You, Ann.
Hi.
I'd like to take a look